Back, it felt very important to me to kind of give you a heads up on what, in my opinion, is one of the most confusing and difficult concepts to grasp in neurology, and that's the basal ganglia. The importance of the basal ganglia is before you want to carry out a motor function from your precentral gyrus, you have to first think about it. So in a way, your brain has to think about something just to make it a little extra. This can get really confusing, especially when you start throwing in all the different pathologies on what can go wrong and what can go right. But hopefully, by using the pathways that I'm presenting to you, it'll help break things down, make it much more simpler, and you don't have to think about it when it comes to test day. So the first thing I wanted to do is just have the different cross sections the way your professors can present it to you. You can either do kind of a anterior, posterior, or transverse cut showing all of the different nuclei to the basal ganglia. This is probably more specific to lab. Once again, where you just have your caudate, putamen, and your globus pallidus. Those are going to be your big players. What you can't see from this cut is your subthalamic nuclei or a midbrain cut, which I will save for later, of your substantia nigra, which will be huge factors later on down the line. Here in the coronal cut, you actually can appreciate the caudate nucleus respectively and the subthalamic nucleus. And you also have over here your putamen and your globus pallidus internal over here, and your globus pallidus external or lateral. So without further ado, let's go ahead and get into this, you guys. So like I said, basal ganglia. The big thing is trying to work out motor function. This can get a little bit confusing with your cerebellum, but hopefully at the end I have a way of kind of explaining how the cerebellum plays into motor function in addition to basal ganglia. But the big thing to take away from it is remember how you have your central sulcus where your primary motor cortex exists. Well, before a signal goes to your primary motor cortex and is sent down to the spinal cord to carry out an action in your arms, legs, or wherever, it also has to go through the pre-motor cortex, which is just in front of the precentral sulcus here. Okay? Another thing to kind of get straight in your head is knowing that the default status of your basal ganglia is going to be suppressed movements. So you have to engage the direct pathway in order to carry out a movement, or if you want to continuously have your motions inhibited, you would engage in the indirect pathway. The whole purpose of your basal ganglia is once again to make smooth actions. Obviously, you don't engage your basal ganglia when you engage a reflex, whether it be your biceps reflex or your patellar reflex whenever you're just whacking a kneecap with a hammer. That's just all carried out in that reflex loop that we've talked about earlier in the tracks lesson. But instead, it's just to make like more complex movements much more smoother. You obviously wouldn't want to engage in a reflex type of movement if you're picking up a pen or reaching out to pick up a remote or some sort of food item when you're just chilling on the dinner table. Another important thing, like I said, is I went ahead and just showed you like a coronal section just to show what they look like. This one, the reason why I love this photo is the caudate and putamen are referred to as the striatum, and here you can clearly see that relationship of the internal capsule as well. The reason why I believe it's called the striatum is you can clearly see these lines communicating back and forth between the caudate and putamen, so you can kind of see why they have such an intimate relationship. And going right in between it is the internal capsule, which is going to be sending your signal to the to the primary motor cortex, and then through the primary motor cortex down to your spinal cord. So, like I said, it's not necessarily wanting to completely take over the motion of whatever you want to do with your arm or leg, but rather just trying to make that motion more smooth and fluid. And of course, you can kind of see down here your globus pallidus. It's hard to distinguish the lateral or internal. Just know that if you were ever to see like a label on something, if it's going to be labeled all the way over here, just guess globus pallidus internal and globus pallidus external out here on the lateral aspect of it. Okay. And I went ahead and included this picture here because, like I said, you can't really appreciate the subthalamic nucleus, but in other cuts you will be able to. So, this is the big thing. I highly, highly, highly recommend screenshotting this now and just practice drawing it out. This will save you so much like frustration and confusion later on down the line. I will, of course, try to hit the most important aspects of this diagram, but please go ahead and screenshot this now and just practice drawing this out, and it might save you some frustration later on. So, like I said, the basal ganglia, what's the purpose of them? You're trying to make a smoother movement of your arm, leg, or limbs, or whatever motor movement you're wanting to do. So the signal is going to begin in the premotor cortex of the brain. That is, once again, before you enter to the primary cortex, which is going to be on the precentral gyrus, which at this point I assume you guys have become very familiar with the central sulcus, and here's your precentral gyrus. So we're going from the premotor cortex to the first stop, the basal ganglion, which is the caudate/putamen. Usually is just referred to as the striatum. This is where you're going to initially input your signal from the premotor cortex to the basal ganglia. Once it enters this, it can either engage in the direct pathway or it can go through the indirect pathway. By engaging the direct pathway, you are going to want to promote said fluid movement. The way it will do that is it will go ahead and inhibit the brake, which I also went ahead and provided this visual to help make this concept very clear. The brake of the basal ganglia is the globus pallidus internal and your substantia nigra, and this is the important part, pars reticularis, because we'll get into this with the Parkinson part of it, but the substantia nigra, is, the other part of the substantia nigra is going to produce your dopamine. So once again, our brake in this system is going to be the globus pallidus internal and the substantia nigra pars reticularis. So anybody that's driven a car knows that if you take your foot off of the brake, you are going to be able to carry out a movement. You're going to either go faster or you are just not going to have as much friction on your tires when you're going the road. So by disengaging the brake, you are inhibiting the brake, so to speak. This is a common term used in physiology moving forward, but you are inhibiting the inhibitor. So by doing that, you and engaging the direct pathway, you are going to decrease the amount of GABA that the brake is releasing, and the thalamus, more specifically the ventral anterior nucleus of the thalamus, is going to carry out its action. It will release glutamate, an excitatory molecule, to tell the cortex, okay, go ahead and send your signal down through the internal capsule to the spinal cord. So once the thalamus gives the okay, the cortex will carry out, and then this smooth movement going from the cortex to the spinal cord will be carried out. That's the direct pathway. One thing to also note is that you'll have different molecules here. GABA tends to be an inhibitory or non-excitatory molecule versus glutamate, which is an excitatory molecule. So like I said, the GABA is going to inhibit this area, the globus pallidus internal and the substantia nigra pars reticularis, our brake. So how does the indirect pathway work? Well, the indirect pathway, think of indirect inhibitor. I'm going to say it one more time. Indirect pathway inhibits. And what it's going to do is you're going to engage the globus pallidus external, because the indirect pathway is also sometimes deemed the external pathway. So you will engage the globus pallidus external, then you'll engage the subthalamic, and the subthalamic nucleus will release glutamate. So as I mentioned before, glutamate is an excitatory molecule. So when the subthalamic nucleus releases glutamate, it is going to excite the brake. So instead of inhibiting the brake, we are going to just slam down on the brake. Like if you just were driving down and then like something showed up in front of you, like a deer hopped out in front of your car, you're just going to just jam on that brake as hard as you can. That's the purpose of the subthalamic nucleus. Now, as I mentioned earlier, just as kind of like a ground rule, so to speak, is your brake is always partially engaged. There's always friction on your tires when you're driving down the road. That might be a little bit of a throwback to physics, but just always think that this is always going to be on, but the extent at which it's going to be on is entirely dependent on the relationship of your direct pathway and indirect pathway. So once again, indirect inhibits by engaging the globus pallidus external nuclei, engaging the subthalamic nuclei. Once the subthalamic fires its glutamate, it's going to encourage or excite the brake. The brake is going to be just slammed shut. This will increase GABA, shutting down the thalamus, and without the thalamus being able to send out its signal, by decreasing the glutamate, the cortex is not going to be carrying out a signal, and you can't get a signal out to the spinal cord. So once again, you're slamming the brake, thalamus isn't working, therefore the cortex and spinal cord are not able to send a signal out, and you will not engage in a movement. That's the indirect pathway. And once again, this is just me kind of showing you how it works. Once again, the globus pallidus external will engage the subthalamic. The subthalamic will just throw out this glutamate here. You will have an increase in GABA here, and your thalamus is thus inhibited. So once again, if you haven't already, please draw out this pathway. It will help you significantly. So, now, like I said, and this is once again just an exaggeratory, the direct pathway, going from your striatum nuclei. You are going to release GABA. It is going to inhibit the inhibitor, globus pallidus internal, / your substantia nigra pars reticularis. By doing this, you are instead of increasing GABA, you are decreasing GABA. You are decreasing an inhibitory molecule. The thalamus gets the go-ahead. The thalamus will tell the cortex, make the motion happen, make it fluid, and then once again, the spinal cord will be able to send the signal to the respective limb that you're sending a signal. Now, this is where we get into the good stuff. This is where you're going to have odd patient presentations, and you have to figure out where the lesion is. This is a hot topic in the tracts, and the basal ganglia are no exception. So what happens in hemiballismus? Well, if I haven't made it clear yet, the indirect pathway is responsible for inhibition. So in hemiballismus, you lose the subthalamic nuclei. By losing the subthalamic nuclei, you in essence lose your ability to put on the brake. And so what happens when you lose the ability to turn on the brake is you have what's called a hyperkinetic disorder. You are unable to stop motion on something. And what does it look like? Well, it's usually an exaggeratory flinging of limbs is how it's been described. Usually the subthalamic is taken out, just like with other stuff in the cerebrum, through some sort of infarct or stroke. Specifically the lacunar artery. Another very important point, which I will get to later, is that this is not bilateral. Usually, just like if you were to have a stroke of your right cerebrum or your left cerebrum, your presentation will be on the opposite side. So if you had a stroke on your right subthalamic, you're going to have hyperkinetic disorder or flinging of the limbs on the patient's left side. So their arms will just go in usually circular patterns of some sort. And that is, once again, as a result of having a lesion to the subthalamic nucleus. You lose the indirect pathway, the direct pathway takes over, and so now you have an overabundance of thalamic and cortex movement. And I wasn't sure if I would be allowed, due to YouTube's rules, to put up a video of what hemiballismus looks like, but I strongly encourage looking up a video just so we can kind of help better visualize what exactly hemiballismus looks like. Same thing with Huntington's chorea. You've probably heard about this in your genetics course, but just like with losing the subthalamic nuclei, you lose the indirect pathway. Without the indirect pathway, you don't have the ability to inhibit motion. You have what's called a hyperkinetic disorder. This is once again, but instead of losing your subthalamic nuclei, you have an atrophy of your caudate. Now, since this is a genetic disorder and it's not like a specific infarct or lesion, it will present as a bilateral loss of inhibition. So you will have a flinging of both your left and right arm, or flinging of both your left and right leg. You will also have a strong family history of it. So usually they'll say like a mom or dad in the past has had it. Usually it'll present later in life, like 40s or 50s. And I know that it can be highly variable, but that's how you're able to fish out that it's Huntington's chorea versus hemibolismus. And once again, you are losing out on this indirect pathway, so it's a hyperkinetic disorder. Your direct pathway is going nuts. You are inhibiting the inhibitor here, and your thalamus and cortex are just having a heyday with it. So that's Huntington's chorea versus hemibolismus. Now we have reached the opposite side of the spectrum. We are at hypokinetic disorders. The big kind of well-known hypokinetic disorder is Parkinson's disease. As you probably have noticed at this point, is we've added one more little kind of limb to our drawing, and that's the substantia nigra pars compacta, like a compact car, as opposed to the pars reticularis. So it's going to be the polar opposite of the pars reticularis. The pars compacta is going to engage the direct pathway. You're wanting to inhibit the brake, versus the pars reticularis is the brake itself. So the best way I could describe, if you haven't caught on to the many allusions to cars and vehicles, is Parkinson's disease is like being in a car with somebody that's first learning how to drive a stick shift or a manual. You're able to like engage the motion, but you have to have a lot of intention. It's very jerky. You're just frustrated and just can't seem to get anywhere in life. So that's how I would best describe Parkinson's disease, is that you will lose the direct pathway, but you have an excitation of the indirect pathway. And so you have to really try hard in order to engage in a movement, and by the time you get to it, it's just very jerky, has plenty of tremors. But I'm getting ahead of myself. With this drawing, like I said, I've included the substantia nigra pars compacta, but now we are engaging the dopamine receptors in the striatum, or the caudate and putamen. For the D1 receptor of the striatum, you are going to directly engage the direct pathway. So instead, you are going to have an increase in GABA, which is going to inhibit our brake, inhibit the inhibitor, and you are going to encourage motion or movement through the pathways we've already talked about. However, in addition to encouraging the direct pathway, you are also going to be inhibiting the indirect pathway. So it gets it from two fronts. You are going through the direct pathway, and you're going through the indirect pathway. And I also, just as an aside, I included a cross section just so we could kind of, recognize and appreciate the pars compacta and pars reticularis, and the where they would with the substantia nigra, and how what a Parkinson's midbrain would look like. And you can definitely see the complete atrophy of that area here in the midbrain pedicles area. So what does it look like? So the big thing with this one is for Parkinson's, you completely lose out your substantia nigra pars compacta, when you can definitely see and appreciate it through this picture. What does that look like? Well, let's go for the easy one. You've lost the ability to excite your D1 receptors in your striatum. Without being able to excite your D1 receptors, you are unable to inhibit the inhibitor. You can't stop. You can't take your foot off of the brake. It's just always on. And just like I said, it's also a two thing. And so you're not able to engage the D2 receptor, aka you're not able to inhibit the indirect pathway. So, and one thing that makes it worse is not only are you unable to inhibit it, but acetylcholine will actually go in here, because you may not have dopamine, but there's plenty of acetylcholine around, and that will excite the indirect pathway, and the indirect pathway will now have a stronger signal due to a lack of dopamine, because something has to fill in that receptor. And so, like I said, it's kind of like a double whammy, so to speak. You lose the ability to engage the direct pathway, and the indirect pathway is hyper-excitable and is taken up by acetylcholine. So that's why Parkinson's disease, by the lack of dopamine, can be so bad as far as basal ganglia are concerned. I know this is just kind of a classic presentation of what Parkinson's disease will look like. Like I said before, if you can, just Google what Parkinson's disease will present like. But you will always see in like question stems or something a Parkinsonian gait, a shuffling gait. You will have a resting tremor because the basal ganglia are knocked out. Mask-like faces. Once again, this is because of involvement to the muscles of the face. You will have a forward lean, so that way they can engage in walking. The arm swing is greatly reduced, because that's how we gain a lot of our momentum whenever it comes to walking. And if you have a disability, you don't have the ability to engage the direct pathway, then you have to try and you aren't able to generate a larger arm swing to get momentum going. And I included this. I don't know if you guys are going to need to know this, but say if a patient presents with Parkinsonians and you almost are certain that the substantia nigra, specifically the pars compacta, is affected, you would give them levodopa, which will which will cause an increase in dopamine within the brain. Particularly here, it will be able to engage the D1 and D2 receptors of the striatum. So, what other, and I wanted to include this, I don't know if you guys will need to know this, but what other hypokinetic diseases that can present like Parkinson's disease? Patient history of Wilson's disease. A good way of that the boards will throw a question at you is they'll show a picture of this, and you can recognize the copper rings around the iris, and you would ask, okay, how would the patient present? What do they have? And that's because Wilson's disease, the patient has an inability to metabolize copper, and it just deposits all over the place, specifically in the putamen of the basal ganglia. So by doing that, you lose the ability to engage the direct pathway. The indirect pathway will take over, and you will present with Parkinson's-like presentation. So, like I said, just look for these. These are called Kaiser-Fleischer rings, in case that ever pops up. It's the inability to metabolize copper, and you are directly damaging the putamen. So what other things can cause damage to the putamen, specifically methanol poisoning? Certainly, whenever you consume methanol or moonshine, there's going to be lots of other damages, but specifically to the basal ganglia, it's damaging the putamen. You lose the ability to engage the direct pathway, and so you will have a presentation similar to Parkinson's. This will present with a history of some sort of alcohol consumption. I suspect they'll probably throw like a B12 deficiency, something like that at you. Another thing is by consuming antifreeze. The way that you would be able to fish out antifreeze is you would ask to look at a UA result and find these calcium oxalate crystals in their urinalysis. That's how you can kind of diagnose whether a patient has antifreeze poisoning in addition to Parkinson's-like symptoms. And that is, once again, just to hash back to it, is a direct damage to the putamen. So, with that in mind, this is me just kind of calling back, because I know with the basal ganglia and cerebellum, they both are creating some sort of tremor and some sort of inability to carry out some smooth motor movement. So how do you fish out a basal ganglia problem versus a cerebellum? Well, that's the purpose of this slide. Is a basal ganglia will usually present with a tremor at rest. Kind of like with Parkinson's disease, we had a resting tremor. However, with the cerebellum, whenever you're trying to engage emotion, you will have a tremor then. So if the patient's arm's just resting there, sitting on their leg, there isn't a tremor. And then the second you tell them to go ahead and touch the end of your finger or pen or something like that when you're doing your neuro exam, and all of a sudden the tremor just starts showing up out of nowhere, then you're like, okay, this is probably a cerebellar problem versus a basal ganglia. And then also to this, the basal ganglia, because it's up in the cerebrum, similar to having like an MCA stroke or something to that nature, or ACA stroke, where you will have presentation contralateral or opposite to the lesion. So if you had a lesion to the right basal ganglia, you will have some sort of resting tremor in the left leg or left arm. And it's the opposite for cerebellum, where it'll be ipsilateral to the lesion. So if you had a right cerebellar lesion or some sort of damage, cancer, what have you, whatever the question wants to throw at you, is going to be on the same side. So a right cerebellum lesion will cause right ataxia or right tremor on the right arm and right leg. And finally, this one, I honestly couldn't tell you what the purpose of the hyperdirect pathway is. I assume maybe this is like an internal reflex pathway or something to that nature. But it's a really easy one to kind of understand, and it's really frustrating if you were to miss the question. But the hyperdirect pathway, the purpose of it is I would consider it like the emergency brake of any of these pathways we've talked about. It is a direct link from the cortex back to the subthalamic. I assume they would use this as a way to directly inhibit emotion you no longer want to carry out, like immediately after it's passed through the basal ganglia, and it's just like, nope. It goes back. So the cortex will directly release glutamate, which I've mentioned here, and here is an excitatory molecule, and I call it the super brake or emergency brake. You are immediately going to engage the subthalamic nucleus. The subthalamic nucleus is going to super engage the brake, and all of like the motion going to the thalamus and all those signals is going to be immediately discontinued. So, like I said, I'm not really sure the purpose of the hyperdirect pathway other than just to immediately cut off like some sort of motion that's going on. Just be aware that it's there and how it could present, knowing that you are engaging the subthalamic nucleus, the signals coming directly from the cortex. And with that, I'll go ahead and end it with you guys. I'll see you at the thalamus video.